Thank you for all for coming and taking part in International Medical Congress of Silesia 2023. My name is Maria Stets, and it is my great pleasure to coordinate the non-invasive cardiology session this year. I would like to cordially welcome the esteemed jury. Professor Tomasz Kukulski, the head of our jury today. Welcome. Professor Beata Średniawa, profesor Jolanta Nowak, profesor Andrzej Tomasik, profesor Maciej Haberka, profesor Krzysztof Szydło, profesor Maciej Wybranis, Professor Maciej Kaźmierski, who is with us online today, and of course, Dr. Artur Filipecki. Welcome all and thank you all for coming. Dear participants, before we start the first prelection, let me explain for you the principles and rules of the session. The order of the presentations will be the same as the abstract book published previous to the conference. The maximum time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time of the prelection, he or she needs to move on quickly to the conclusion section, of course. And please remember that all of the presentations, of course, must be run in English. You will be assessed based on the scientific value, way of the presenting, the discussion, and your own contribution to the paper. Esteemed jury, when the session ends, we kindly ask you to give the cards back to the coordinator and please assess the papers in 1 out of 5 points for each of the criteria. I will hand you all the assessment forms in a minute. So we can start now, I hope, if we don't have any questions or any other issues. So let me introduce you the first presenter, Mrs. Natalia Bukała, and the paper ECG in the differentiation of right ventricular dilatation with and without pulmonary hypertension. Natalia, are you here with us today or should you be connected online? If I cannot see you, then we can all move on to the second presentation. Then I came with the presentation on correlation between the relative expression level of MIR10B particles and advanced arteriosclerosis lesions. The floor is yours. Yeah, it should be turned on.
Yeah, can you turn on the slides?
Space button.
All right. Yes, hello, my name is Taneki. Okay. Hello, my name is Sunny Kim. I'm a
Sorry. Can you see us now? Great. Now we can definitely.
Okay. Okay. Hello, my name is Sunny Kim. I'm a fourth-year student at Medical University of Warsaw, and today I'm going to present about the correlation between the relative expression of MIR10B and advanced atherosclerotic region. So let's start. So what is atherosclerosis? Atherosclerosis is a chronic arterial disease and leading cause of vascular death worldwide. Atherosclerotic plaques consist of lipid droplets, cholesterol crystals, inflammatory cells, and necrotic fields within the extracellular matrix that deposits on the wall of arteries, which causes narrowing and hardening of arterial walls. There are two main phenotypes of atherosclerotic plaques, which is stable and unstable. Various factors participate in the progression of atherosclerotic plaques, such as KLF4, which is arteroprotective, and MIR10B, which is an inhibitor of this factor. What is MIR10B? MIR10B is a small non-coding RNA, which is involved in various biological processes, such as embryonic development, self-proliferation, and also apoptosis. From pathophysiological point of view, it is involved in endothelial dysfunction and cancer progression and metastasis. And in specific, it promotes the migration and invasion of the cancer cells, and also it enhances its resistance to apoptosis. One important thing to mention is that MR10B downregulates the expression of KLF4, which is also called Creutzfeldt factor 4. KLF4 is involved in maintenance of integrity of the endothelial cells, and also maintenance of endothelial cells, and also it has anti-inflammatory function, and it inhibits the arteriogenesis. This study aims to investigate whether the relative expression level of MR10B varies in patients depending on the progression of atherosclerosis. This study was conducted using case control retrospective study comparing 8 patients with advanced atherosclerotic plaques and 8 patients without advanced atherosclerotic plaques. Then we analyzed the relative expression level of MR10B in both groups. The results have shown that in the group of patients with coronary atherosclerosis and with advanced atherosclerotic plaques, the expression level of MR10B is 0.138. In standard deviation, it is 0.086. And with patients with coronary atherosclerosis but without advanced atherosclerotic plaques, the expression level of MR10B is 0.061. In standard deviation, it is 0.041, leading to the probability of 0.044. In conclusion, we found that the relatively higher expression level of MR10B is found in patients with advanced atherosclerotic region, which suggests the role of MR10B in progression and development of advanced atherosclerotic plaques. But further studies are needed to fully explain the role of MR10B and atherosclerosis, and its potentials as a therapeutic target. Thank you very much for listening. I will gladly answer your questions.
Do you have any questions?
Congratulations for an excellent presentation. How many patients have you recruited and analyzed?
We recruited around, I was organizing the information of around 30 patients, but we excluded the patients with history of myocardial infarction or active infectious disease or active cancer, and then which might affect the results of the research. So in conclusion, we analyzed 8 patients with advanced atherosclerotic region and 8 patients without advanced atherosclerotic region.
How have you selected the MIR10B from the plenty of microRNAs potentially involved in atherosclerosis?
First, we analyzed various RNAs using double delta method, and from there we found out that MR10B is the significant factor that depends on the expression. It depends on the extension of atherosclerotic plaques.
Thank you.
Thank you.
Did you perform the coronarography in this group?
Sorry, coronary what?
Coronarography.
Yes. We
perform gold standard, and because it is nothing about the results from coronarography. It is advanced coronary artery disease, yes. So how it looked like coronarography in these patients? It was 1 vessel disease, 2 vessels, 3 vessel disease, and how was calcium score in tomography, because it is advanced coronary artery.
Coronary artery disease.
So in this presentation, what we mean by advanced atherosclerotic plaques is the group of patients with coronary atherosclerosis that has severe stenosis and who require stenting.
With at least 2 vessel disease.
Yes.
And the indication for stenting, yeah?
Yeah.
That's what I understood.
Yes.
My question would be, what was your personal input to this work?
So my input was to analyze the patient's history, go through them, and select the needed information and make it as a table so that we can compare it easily. And then we analyze the results and then compare the results depending on the groups of patients. And I made the presentation and the abstract.
Okay, if there's no other questions, so...
Formalne kwestie
So, thank you for your presentation.
Okay, thank you.
Thank you so much. And now we can move on to the presentation number 3, Mr. Marcin Goławski, I believe, lipoprotein A levels in Parkinson's disease, a 2-sample Mendelian randomization study. You receive the microphone?
Yeah,
Hello.
thank you. Okay. Good morning. My name is Marcin Goławski, and it is my pleasure to present to you the results of our Mendelian randomization study regarding lipoprotein A levels and Parkinson's disease. How should I? Oh, okay. Yes. So what is Mendelian randomization? Well, it is a method of eliminating biases and confounding factors from observational studies through the use of randomly inherited genetic variants. Basically, if we know that a variant causes some kind of exposure like high LDL cholesterol levels and also is associated with some kind of outcome like coronary artery disease, then as long as the variant is not causing the outcome through any other mechanism than the exposure, we can confidently say that indeed the exposure causes the outcome. So now onto the rationale for this study. The correlation between high lipoprotein A levels and coronary artery disease is well known, but exact physiological role of lipoprotein A is still not well elucidated. Because there are several lipoprotein A levels lowering drugs in the pipeline, we decided to perform a Mendelian randomization study regarding lipoprotein A and Parkinson's disease to elucidate whether those drugs may have some sort of adverse event related to Parkinson's disease. Now on to the method section. We collected the data for lipoprotein A levels from UK Biobank and data for Parkinson's disease from FinGen database. This is so-called two-sample Mendelian randomization. That is, the correlations are collected from two separate samples. This is actually an approach that eliminates some biases. The primary analysis was the inverse weight mean, which is somewhat similar to typical meta-analysis. We utilized several variants from LPA gene region that were not in linkage disequilibrium and had a genome-wide statistical significance for lipoprotein A levels. And the secondary analysis were MR-EDGER, which I will explain briefly, weight median and mode, and sensitivity analysis was conducted by randomly selecting 70% of the variants. Now on to the results. So on those graphs, each dot represents a genetic variant. On the x-axis is the correlation with lipoprotein A levels, and on the y-axis is correlation with the odds ratio for Parkinson's disease. As we can see, there is no clear correlation between the two, and the difference between inverse weight mean and MR-EDGER is the fact that the trend line does not have to go through the 0 point in MR-EDGER, although it should if the assumptions of a Mendelian randomization are indeed correct. Now, also, the data incorporated around 300,000 participants for both lipoprotein A and Parkinson. None of the methods yielded statistically significant result. And there was some heterogeneity between the variants, but it is actually quite acceptable. And the 30% out analysis did not indicate any significant problems. Now on to the discussion. So we can confidently say that there is no causal role of lipoprotein A in Parkinson's. So either the PCSK9 inhibitors that are on the market or the experimental drugs that aim to reduce lipoprotein A levels are not likely to cause Parkinson's disease. Thank you very much for your attention.
Regarding this.
Thank you for your presentation. Congratulations for the concept of this work. Could you tell us something about the practical aspect of the access to UK Biobank?
So we use so-called Pan-UK Biobank. This is a group that basically summarized all of the data collected in UK Biobank in so-called summary statistics format. So for each variant, you have the correlation and the standard error, which is sufficient to conduct this analysis. And this data is publicly available.
Any further questions?
Any other questions from the jury?
Oh yeah, I think maybe I should add what was my role in the research. I think I didn't specify that. So basically, I collected the publicly available data, conceptualized the study, and then interpreted the data and created this presentation while my tutor performed some calculations in our program.
Okay. So thank you for your presentation.
Thank you. Thank you. Congratulations. In that case, we will move on to the third paper by Marcin Schulz, vascular stiffness and endothelial function in patients with coronary artery disease and diabetes. The floor is yours.
Good morning, ladies and gentlemen. Thank you very much for invitation. Dear jury, dear colleagues, my name is Marcin Schulz, and I want to present results of research carried out by student scientific group in second department of cardiology in Zabrze. To introduce, diabetes causes macro and microangiopathy that causes coronary artery disease, and that leads to ischemic events. To be more specific, patients with impaired glucose tolerance and type 2 diabetes have higher risk of atherosclerosis. Metabolic syndrome leads to inflammation, thrombosis, and together with hyperinsulinemia causes endothelial dysfunction. All problems are connected with insulin resistance. There are some markers that can indicate coronary artery disease and peripheral artery disease. Soluble suppression of tumorigenesis 2 is a marker of inflammation and thrombosis, elevated in patients with higher vascular risk. Reactive hyperemia index, abnormalities in this parameter are an early sign of generalized atherosclerosis. Central and peripheral pulse wave velocity are also related to arterial stiffness, elevated in patients with diabetes. European Society of Cardiology recommends maximum 10 meters per second. Ankle brachial index is a long-recognized parameter of peripheral artery disease and should be in range 0.9 to 1.15. The aim of our study was to compare vascular function in a group of 50 patients. All of them have angiographically defined coronary artery disease. 29 patients with diabetes, aged 68.9 plus minus 7.5, and 21 patients without diabetes, aged 66 plus minus 7. Endothelial vasoreactivity was measured with endopath device. Based on PAT technology, non-invasive endopath system comprises a measurement apparatus that supports a pair of modified plethysmographic biosensors. Peripheral arterial tone signal is measured from the fingertip by recording the peripheral finger arterial pulsatile volume changes. Central and peripheral pulse wave velocity and vascular age was measured with a Complior device based on applanation tonometry. To proceed measurement, we need three sensors. First, place on carotid artery. Second, on femoral artery. They both measure central pulse wave velocity. Second sensor is placed on radial artery. Together with carotid sensor, it measures peripheral pulse wave velocity. Attached software analyzes results and shows vascular age. Ankle brachial index was measured with Watch PP Office ABI device. To proceed measurement, we need two manches. First, localized on upper arm, and second, near ankle. Attached software automatically shows results of ABI. The concentration of soluble suppression of tumorigenesis 2 was measured with aspect reader critical diagnostics. Device measured fluorescent signal and shows results on screen. On this slide are shown results. Only difference in three parameters were statistically significant. In central pulse wave velocity, mean vascular age, and concentration of soluble suppression of tumorigenesis 2. In the rest parameters, there were no significant differences. So patients with type 2 diabetes have higher levels of central pulse wave velocity, mean vascular age, and concentration of soluble suppression of tumorigenesis 2. In the rest parameters, as were mentioned before, there were no statistically significant. Coronary artery disease patients with diabetes have significantly higher central arterial stiffness and vascular age. It may result from increased fibrotic processes as evidenced by elevated SST2. Our results suggest that impact of diabetes on central vascular bed may explain the increased vascular risk in this specific group of patients. On this slide, you can see our research team. And thank you for the attention, and we invite to the discussion.
Thank you for the presentation. Do we have any questions from our jury?
Congratulations for your work. Those are very valuable methods. However, they are very time consuming. How much time did you spend on one patient with all those methods?
To examine one patient, it is
1 hour?
Approximately 45 minutes to 1 hour.
Okay, so you have a very high personal input in this work. And do you think that one of those methods is to be put in a clinical practice, everyday clinical practice? This is the problem with those methods. They are very good, but very time consuming.
Yes.
Do you think that which of those methods you used is able to be put in our everyday practice? Tonometry or any other?
I think tonometry will be very successful in the future. And also very interesting.
Is about 20 minutes. How much time did you spend on tonometry? 20 minutes, 30 minutes?
20 to 30 minutes.
Okay. Thank you very much.
Congratulations for your work. Short question concerning the methodology. You used the measurement of the pulse velocity. Could you clarify what is how you interpret this data? Because the patients with diabetes had a higher velocity of pulse wave, and you concluded that the stiffness in this group was lower. So what is the relation between the pulse velocity and the stiffness?
Thank you for this question. Of course, patients with diabetes may have higher values, but we do not diagnose the diabetes and the vascular dysfunction in this method. In this study, we wanted to show and make a step further to better understand the pathophysiology of coexistence of coronary artery disease and the diabetes. And I guess one of the most important things in this study was to show the correlation of the process of fibrosis. But of course, we agree that the measurements of vascular stiffness in patients with diabetes may be really hard to interpret.
Okay, thank you.
Congratulations. I would like to ask how costly is assessment of SST2? We have seen this methodology on the slides, but how it is expensive?
We know that this method is not commonly used, and the producent of the method of this things to measurements the soluble tumorigenesis 2 factors. I don't remember, and we don't remember exact cost of one person, but we must remember that we need only special equipment and special proofs, and we can make these measurements in our world, not in the laboratory, which is really, but the cost is still really high.
If there's no further questions, so thank you for your presentation.
Thank you so much. I believe we should move on to the fourth presentation by Mr. Oskar Woźniak. Does multimorbidity influence on early effectiveness of pulmonary arterial hypertension treatments?
Good morning, ladies and gentlemen. My name is Oskar Woźniak, and I would like to present to you our research result on influence of multimorbidity on early effectiveness of pulmonary arterial hypertension treatment. Pulmonary arterial hypertension is a rare disease consisting of progressive obliterative vasculopathy characterized by remodeling of pulmonary capillaries. Morbidity is low. In 2022, guidelines for treatment of patients with PAH were changed. Before that, all patients had start treatment from monotherapy, and next, medication was added. What allows us to make this study? Now, patient without comorbidities start treatment from polytherapy, and patients with comorbidities are on monotherapy. The aim of our study was to assess an influence of comorbidities on effectiveness of early treatment among patients suffering from PAH. Our study was retrospective analysis with 45 patients hospitalized between 2012 to 23 in the first department of cardiology in Medical University of Silesia. We divide patients into two groups, Group A with 2 or more comorbidities and Group B with 0 or 1 comorbidity. 77% of patients were females. We exclude patients who begin treatment before first hospitalization, patients who left the second clinic control, and those who second control was after a longer time than 6 months. We have analyzed parameters as form of therapy, WHO class, NT-proBNP, and 6-minute walk test, and echocardiography markers of PAH. In our study, we include comorbidities as diabetes mellitus, systemic hypertension, coronary artery disease, chronic kidney disease, and chronic obstructive pulmonary disease. Average age in Group A was 64.9, and in Group B it was 49.6. On the slide, you can see a percent distribution of patients between groups. On this slide, you can see a percent distribution comorbidities between patients. 50% patient from Group A and 24.1% patient from Group B have class WHO before treatment. after 6 months of treatment, just 6.3% patient from group A and 3.4% patient from group B have also class 4. So the treatment was really effective. Sorry. Applied treatment, monotherapy and polytherapy was similar between groups. In group A, more often was used phosphodiesterase inhibitors than endothelin receptors blockers, unlike in group B. Anti-pro-BNP have decreased in both groups. Distance in 6-minute walk test increased in both groups, but much more in group B. TAPCE increased in group A and decreased slightly in group B. RVSP decreased in both groups. And TAPCE RVSP index increased in both groups. Retrospective analysis demonstrate that patients with comorbidities were characterized by older age and more advanced signs and symptoms of pulmonary arterial hypertension. Employing of monotherapy and polytherapy was similar between groups, and effectiveness of treatment based on 6-minute walk test, NT-proBNP, and echocardiography parameters were more efficient in group of patients without comorbidities. And I would like to introduce my team.
Thank you, fine paper. And I would like to ask you, as you remember, in exclusion criteria, you had the absence during the second visit during this program of treatment. And very easy, I hope, question, why?
Thank you for this question. Absence on second visit was mostly during pandemic, and a lot of our patients had online consultation, and he hadn't. So, example, 6-minute walk test. So we excluded them from this study.
Okay, fine. Now I understand.
Thank you. This study is assessed of new guidelines of treatment, and we must make a bigger database and much more patients for more better outcome of this study. Yes, I hope this, because nowadays we have more elderly people with this disease.
I would like to congratulate you on your work, but I have one remark, because you showed the dynamics of certain factors, for instance, like 6-minute walk test in one and second group, but you showed only one p-value, and I would like to ask you, what does this p-value refer to? Because like there was a change, for instance, of 6-minute walk test in group A and group B, and does this one p-value indicate I mean, because you have two groups and only one p-value. So it may be either the comparison of the dynamics in both groups. This is a very sophisticated statistical method, or it's simply a paired test within one group. So the value at point A and point B.
This point value was to the changes in the groups.
Okay, so sorry. So this was a comparison of delta value in both groups.
Yes.
Okay. Because it wasn't like apparent in the. Okay. But it's a very good. This is one of the ways to compare it. Very good.
Your data.
So because the changes might have been determined by the initial baseline value. So you always have but the extent of the decrease is important. Thank you.
Thank you very much.
We can move on to the next presentation, I believe. Congratulations. And now Mrs. Julia Dołęga with presentation number 6. To be exact, echocardiographic criteria suggestive of pulmonary hypertension and clinical characteristics predisposing to PH phenotype in patients with PHF.
Good morning, ladies and gentlemen. My name is Julia Dołęga, and today I would like to share with you the results of our clinical study about echocardiographic criteria suggestive of pulmonary hypertension and clinical characteristics predisposing to the pulmonary hypertension phenotype in patients with heart failure preserved ejection fraction. As we know, the heart failure with preserved ejection fraction is characterized by left ventricle diastolic dysfunction, resulting in pulmonary congestion and consequently postcapillary pulmonary hypertension, which is an important contributor to clinical deterioration and increased mortality. In this slide, we can see once again the pathomechanism of pulmonary hypertension among patients with heart failure preserved ejection fraction. Our aim was to assess the clinical features predisposing to the echocardiographic sign of pulmonary hypertension in patients with heart failure preserved ejection fraction. We retrospectively collected data of 63 patients with heart failure preserved ejection fraction, including 35 males and 28 females, aged about 72 years old. In our study, we analyzed variables such as clinical characteristic, like as presence of aortic stenosis or presence of mitral regurgitation, symptoms like dyspnea, chest pain, or ankle swelling, TTA parameters like left and right atrium area, EO ratio, or aortic Vmax, and laboratory tests like hemoglobin, creatinine, and NT-proBNP. And now I will present the results of our study. The group was divided according to tricuspid regurgitation velocity into a group with TRV above 2.8 meters per second, which accounted 15 patients, and TRV under 2.8 meters per second, which accounted for 48 patients. It is assumed that TRV above 2.8 meters per second increases the probability of pulmonary hypertension. There were no statistically significant differences between both groups regarding age, height, weight, BMI, or BSA. Baseline characteristics showed that the number of hypertension, diabetes, coronary artery disease, or dyslipidemia and chronic kidney disease was comparable in both groups. However, group with TRV above 2.8 meters per second tended to have a higher incidence of atrial fibrillation, and in this group, noticed greater number of percutaneous coronary interventions. As we can see, the presence of aortic stenosis and VCI was higher in the group with TRV under 2.8 meters per second, and the presence of mitral regurgitation was higher in patients with TRV above 2.8 meters per second. And among echocardiography parameters, statistically significant were right and left atrium area, left ventricle EDD and ESD, E-wave, EA ratio and aortic Vmax, and right ventricle systolic pressure and tricuspid regurgitation velocity. Heart failure symptoms were more exaggerated in the subgroup with TRV above 2.8 meters per second. This group also had a significant percentage of fatigue, ankle swelling, and tendency to dyspnea compared to the group with TRV under 2.8 meters per second. The presence of heart failure symptoms was significantly greater in the patients in the group with TRV about 2.8 meters per second, except for the chest pain, which was similar in both groups. Mean values of laboratory tests included on the slide were within norm, except for NT-proBNP value. And to sum up, among patients with heart failure, preserved ejection fraction, only about 25% presents with moderate features of pulmonary hypertension that are associated with more severe remodeling and dysfunction of the left ventricle, and the features of pulmonary hypertension are associated with atrial fibrillation and are not reflected in the classical comorbidities. Patients with heart failure preserved ejection fraction are still not fully understood group of patients, and our work sheds a light on the importance of assessing the features of pulmonary hypertension. Thank you for your attention.
Congratulations. Do we have any questions for our presenters?
Thank you for the presentation. My question is related to the group analysis. You showed that patients with a low probability of pulmonary hypertension have a greater percentage of mitral regurg. We would expect completely different situation. How would you expect this finding? Is it due to the low number of patients in the group? Because the difference was significant. It was 35 patients with MR in group 2, so in a group of patients with low probability of pulmonary hypertension.
Thank you for your questions. I think we have a small group of patients and we want to collect more patients, and because some of the results of our work was very interesting and not exactly clearly, and we sometimes have questions in our head, what is the problem of different results than in should be.
Yes, I have one question. I think that one of the very important conclusions is that atrial fibrillation is a very important disease in this group of patients. So, what do you think? We should fight with this atrial fibrillation? I mean, cardioversion, maintenance of sinus rhythm, or catheter ablation, or not? Or this observation is based on too small group of patients to think about such a conclusion?
Thank you for your questions. Yes, we can think that we should focus more on these patients with heart failure, preserved ejection fraction, when they are atrial fibrillation and symptoms like this, because it's could be more. It could be better for the patients diagnosed through this group the pulmonary hypertension, and it probably helps them to have more comfortable life with their diseases.
Have you any data about death or recurrent hospitalizations in these patients with atrial fibrillation?
Every patient in our work are still alive, so so it's not any of death about mitral regurgitation or atrial fibrillation.
Thank you. I believe we can move on to the 7th presentation. Congratulations for you. And good to have you here. So Aleksandra Machnik with the exercise lung ultrasonography in asymptomatic severe aortic stenosis, a preliminary study.
Good morning, ladies and gentlemen. My name is Aleksandra Machnik, and I am honored to present to you our work titled Exercise Lung Ultrasonography in Asymptomatic Aortic Stenosis, a Preliminary Study. Next one, please. Presence of aortic stenosis is associated with pressure overload of the left ventricle and impairment of its diastolic function. This leads to increased pulmonary venous and capillary pressure. Presented mechanism results in pulmonary congestion, and pulmonary congestion can be evaluated by lungs ultrasonography, and it is an independent predictor of outcome in patients with heart failure with preserved ejection fraction. Next, please. During our study, we aim to evaluate pulmonary congestion by transthoracic echocardiography and B-lines in lungs ultrasonography before and after exercise in patients with asymptomatic aortic stenosis. Moving on to the materials and methods. Our study consisted of 8 patients with asymptomatic aortic stenosis and left ventricle ejection fraction equaled 50% or more. And however, we excluded patients who presented with symptoms of aortic stenosis, left ventricle dysfunction with left ventricle ejection fraction under 50%, acute coronary syndrome, CRT or ICD implanted, previous cardiac surgery or infection. As for the general characteristics, 37.5% of our patients were male and 62.5% were females. The average age was 76 years, and the most common comorbidities were hypertension and dyslipidemia. The patients didn't present dyspnea and fatigue. Next, please. Let me now tell you about our study protocol. So firstly, we checked vital parameters of our patients like heart rate, blood pressure and saturation. Secondly, we used a modified Borg scale to check the dyspnea and fatigue. Then we performed lungs ultrasonography before the exercise, and the well-qualified doctor from First Department of Cardiology helped us to perform transthoracic echocardiography. Then the patient undergo 6-minute walk test as a form of exercise. And finally, we repeated all of the previous procedures and compared the data. During lung ultrasonography, we used 8-zone method. We summed B-lines in all zones and the amount of zones with 3 or more B-lines. This is an example of B-lines we were looking for in a lungs ultrasonography. In the transthoracic echocardiography, the presented parameters were measured. And moving on to the results of our work. Here you can see vital parameters and TTE parameters before the exercise test. And before the exercise, the lung ultrasonography evaluated that all patients had 1 or more B-line, and 6 patients presented 1 or more zone with 3 or more B-lines. And let me now tell you about the comparison of the results before and after exercise. A mean 6-minute walk distance was 375 meters, and both dyspnea and fatigue, assessed by the modified Borg scale, increased significantly after exercise test. And if you look at this chart, you will see that there was a statistically significant increase in heart rate and systolic blood pressure after exercise. And mean values of TTE parameters were comparable before and after the exercise test, except for the TAPCE, which presumes significantly lower values after the exercise. Lungs ultrasonography evaluations showed crucial increase in overall number of B-lines after exercise, as well as in number of zones with 3 or more B-lines. And what's important, 2 patients presented no symptoms but had an increase in number of B-lines after 6-minute walk test. Moving on to the conclusions, exercise lung ultrasonography reveals pulmonary congestion in patients with asymptomatic aortic stenosis, that it seems to be an additional diagnostic option for this group of patients. Nevertheless, this preliminary observations needs further evaluation. That brings me to the end of my presentation. Thank you for your attention, and feel free to ask me some questions.
Congratulations on your paper. Do we have any questions?
Congratulations, first of all, for the concept of this study. Of course, we understand that this was a very, very preliminary experience with only 8 patients. It's a pity, because we have plenty asymptomatic patients with aortic stenosis. So this method have a potential to identify those who are candidates for early surgery. Till now, we have one established method to look at these patients. So this is exercise test that is used to look at arterial hypertension response. We don't look at any of the echo parameters. We just look at the response of the arterial hypertension. You showed that none of your patients did not reveal a reduction of the arterial hypertension. All of them increased. However, you showed that all of them reveals at least increased in number of lines or an increased number of zones. How would you explain this discordance, that the patients reveal problem with congestion, but they still have good arterial hypertension response?
As I told you, the patients we had preserved ejection fraction, so they presented no symptoms, but as I told you, the pulmonary congestion was the result of the left ventricle dysfunction, diastolic dysfunction, and B lines are the artifacts that we can see in a lung tissue when there is a higher density of the tissue. So that's why we could observe this artifacts in a lungs ultrasonography.
What was your personal input to this work?
So we began with collecting relevant literature and publications about asymptomatic aortic stenosis, heart failure with preserved ejection fraction, and pulmonary congestion and lungs ultrasonography. We learned to perform lungs ultrasonography and how to interpret its results, especially when it comes to B lines. We also learned to perform 6-minute walk test and perform it with our patients. We created an Excel database on this, and basing on this information, we created this presentation for you today. And
did you perform the lung study by your own? No.
Excuse me?
Did you perform the lung study by your own?
The lung ultrasonography, yes, but not the TTE.
Okay, yeah.
Of course. Thank you. Yes. Thank you.
Congratulations. And you haven't mentioned in your input statistical analysis. The group is relatively small, and you used to compare data before exercise test and after. In general, what kind of statistics would you use for analysis of such data?
Honestly, I'm a person who wasn't responsible for statistics during
matched pair or non-matched pair?
Matched pair.
Thank you.
I have just short comment, nearly the same as Professor Kukulski. So the concept is very interesting. However, the cons of the work is the number of patients. 8 patients precludes statistics. And the second thing, I suggest that you would not use 6-minute walk test, because in my opinion, this should be exchanged by just exercise test for the future work. Because you have the time between the once the patient stops the exercise and you start the lung ultrasound must be very, very short. Thank you.
Well,
and what about the artifacts? What about artifacts? Because for me, it's an old method, but very rarely used. The lung.
Well, so I showed you this on one of the slides, but okay, never mind. As I told you, probably B lines are the artifacts that are a pathological view in lungs ultrasonography. And when we have inflammation or fluid in lungs, we can see it changes the density of the tissue, and then those artifacts appear when we have that kind of changes. I know that we didn't have many patients, but we have very promising results, so we are going to continue our work. Thank you.
Thank you. Congratulations for this heated discussion. And now I invite Małgorzata Niemiec with the study about cardiac magnetic resonance used in the diagnostic of acute myocarditis, one-center observational retrospective study.
So, good morning, ladies and gentlemen. My name is Małgorzata Niemiec, and I'm pleased to present you our research regarding cardiac magnetic resonance used in the diagnosis of acute myocarditis, one-center observational retrospective study. The diagnosis of acute myocarditis is complex, therefore, clinical criteria and laboratory tests are not often sufficient to make a final diagnosis. Therefore, more and more additional tests are used, such as endomyocardial biopsy and CMR. Endomyocardial biopsy is the standard of the references in the diagnosis of acute myocarditis, but due to its invasiveness, it's not often performed. That's why the importance of CMR in making a final diagnosis of acute myocarditis is growing. The aim of our study was use of CMR in the diagnosis of acute myocarditis and associations between CMR findings and the degree of myocardial damage as determined by the concentration of myocardial necrosis markers. In our study, we analyzed cases of 19 patients hospitalized in the years 2015 to 2022 after 2 weeks from the clinical diagnosis of acute myocarditis in the first department of cardiology in Katowice. We compared their lab test results such as troponin T, CK&B, C-reactive protein levels, as well as transthoracic echocardiogram in relation to the following CMR parameters: left ventricular ejection fraction, presence of myocardial edema, number of segments with LGE, ROI mass, and ROI percent. Now regarding the characteristic of the study group, patients were divided into two groups, MRI performed and not performed. Out of 90 patients, 39 had MRI performed during their hospitalizations, which is 43%. In our study, were mostly male. Mean age was about 37 to 40 years old. The New York Heart Association classification was about class 1 and 2. Now, I would like to present to you how we counted the presence of LGE in the MRI in the short axis. First, we outlined the left ventricular endocardium. The next step was to outline the epicardial contours. In this way, we obtained the boundaries of the myocardium. Then we got the intersections of the left and right ventricles, the so-called threshold. In this way, we obtain LGE. We mark also ROI mass and ROI percent. Now, I would like to discuss the results of our study. Looking at this table, we conclude that patients with MRI tended to have hypertension, slower heart rate, lower levels of troponin T, CK&B, and C-reactive protein. The echocardiography results were as follows. The group with MRI had higher left ventricular and systolic volume and left atrium area compared to the group without MRI. In the case of left ventricular and diastolic volume, the situation was opposite. From a CMR perform group, 18 patients had left ventricular ejection fraction below 55%. Myocardial edema was found in 28 patients. The number of lead-occupied segments was significant in all cases and ranged from 6 to 10 segments in 11 patients, which makes 28%, to 11 to 16 segments in 28 patients, which makes 71%. There were, as shown the diagram above, there were no significant correlation between left ventricular ejection fraction, number of myocardial segment with LGE, presence of myocardial edema, and troponin T, CKNB, and C-reactive protein levels. There were a significant correlation between ROI mass and ROI percent and left ventricular ejection fraction with CMR and echo. To sum up, although CMR is significant in the diagnosis of acute myocarditis, it is not fully utilized. Current use applies to patients with less pronounced symptoms suggesting the diagnosis. In patients with mild clinical courses of myocarditis, diagnosis markers of myocardial damage are not related to the severity of changes observed on CMR. Thank you for your attention, and I would like to invite you to the discussion.
Any questions regarding this?
My first question to you is about the group with CMR and without CMR, because you compare this group many clinical aspects, but why? What was the aim of this comparison?
Because we wanted to analyze associations between between patient with MRI and without MRI and their laboratory test results, because in 15 patients CMR were not performed because they have a higher laboratory test parameters, so which allow to make a final diagnosis. So we wanted to and the 39 patients in 39 patients CMR were performed because they had no specific laboratory test parameters. So we wanted to compare the results. So
CMR does not have the influence on parameters. There is no the relation, the reason and the clinical aspect.
Yes, the clinical aspect, yes, and because we wanted to analyze how people with a higher laboratory test parameters and not specific laboratory test parameters, what is the association between.
Okay, can we move back to the last slide from the results? Yes, this one. Correlation between the mass and left ventricular ejection fraction. You said that there was significant correlation, but what was the strength of this correlation? Because you have 90%. It's quite good group, but it was 0.3 or 0.6, for instance. Do you remember?
I think 0 to 6, I think, yeah.
0.6, so it's a middle correlation, okay.
Yes, it's a middle correlation, I think.
So I just would like to clarify that I guess that the comparison between MRI and non-MRI group was simply to show how we decide to perform certain diagnostic imaging in a certain patient. I mean, perhaps these patients might have had just luck that the modality was available within the time frame of hospitalization. But I would like to also point out that the correlations you showed were, of course, very interesting, but the patients were admitted on a different stage of the disease, and sometimes the changes in CMR are very volatile. They change, and after 2 weeks, they might be completely different. That's why that these correlations might not have been totally very constructive clinically. However, it's a very good work, and congratulations.
Thank you very much.
And so maybe first of all, comments. The main problem is that you do not have the data. What is the time between the onset of the disease and the CMR? And this is the biggest problem, because sometimes it's a few days, sometimes like 1 month.
It was 2 weeks after.
But you don't have this data. It's impossible to have this data because we nowadays we don't know what is the in fact onset of the myocarditis in most of the patients. I understand that CMR negative patients had biopsy or no?
With no.
No. So in fact, we are not sure if they had the myocarditis.
And myocarditis was the diagnosis of myocarditis was made on the basis of symptoms and laboratory test parameters and echo and ICG after excluding the abnormalities in the artery vessels.
So this is still a suspect. We might suspect, but not definitely diagnose. What is the LV ejection fraction on this figure? It is echocardiography and CMR, because you have this is from CMR. Or
echo? This is for CMR.
CMR. Okay. Okay, that's all from me.
Correlation between CMR and echo, I think ejection fraction of left ventricle and right ventricle too.
We analyze, in our cases, we analyze just a left ventricular ejection fraction. Yes, only left ventricular ejection fraction. So there were significant correlation between in CMR. Yes. Okay.
2D, in 2D and or 3D echocardiography ejection fraction.
3D.
3D. Yes. And what kind of correlation it was?
What kind of correlation?
Yes, between CMR and echo, left ventricular.
It was the same. I think it was yes.
Very like similar.
This is very similar. So this is
And you recommend to use ejection fraction by echocardiography by 3D.
Yes, of course. Thank you very much.
Thank you.
Last question, maybe, if I may. Because as I said, it's quite a good number of patients, 90 patients. Do you think or do you plan any follow-up of these patients? Because we know that after acute myocarditis, we can see positive or negative modeling of left ventricle, especially, or left atrial also. So what about follow-up?
Yes, but this is the retrospective study. But yes, we are going to do a follow-up of this study, and we are going to analyze the associations between acute myocarditis and dilated cardiomyopathy.
Thank you.
Next time? No.
Thank you.
Thank you very much.
Thank you so much. Congratulations. And we are ready to start with the eighth presentation, Mr. Szymon Szostek, and CHA2DS2-VASc score in patients with ischemic stroke as a predictor of atrial fibrillation or recurrent stroke. The floor is yours.
Good morning, ladies and gentlemen. It's an honor to have the opportunity to address such a distinguished audience. My name is Szymon Szostek, and today I would like to report on the subject of the Katowice score, atrial fibrillations, and other indices in patients with ischemic stroke. Atrial fibrillation is an arrhythmia that can cause the ischemic stroke. In the picture, you can see the factors that can cause atrial fibrillation, like, for example, hypertension, diabetes, and other indices. Some of them are part of the Katowice score. The Katowice score is a widely used tool to assess the risk of in patients with atrial fibrillation, to assess the risk of ischemic stroke, and it can say that patient can benefit from taking oral anticoagulants or aspirin therapy. In our study, we were looking for the predictive value of Katowice score and other indices in the prediction of higher risk of atrial fibrillation finding and or recurrent ischemic stroke during the follow-up after the embolic stroke of undetermined source. The other indices were, for example, atrial ectopy, body mass index, excessive supraventricular ectopic activity, National Institute of Health Stroke Scale, and heart rate variability. Study population consisted of 90 patients with embolic stroke of undetermined source. They were prospectively observed for at least 2 years. They were hospitalized in the Upper Silesian Hospital Medical Center in the Katowice, Katowice between 2015 and 2018. Then the Katowice score was calculated for each patient, and we collected and checked other indices such as PAC, EAT, SVEA, atrial hypopnea index, NHSS score, and BMI. And our primary endpoint was the confirmation of atrial fibrillation or recurrent ischemic stroke during the follow-up. The patients were strictly selected. They must be over 18 years old with confirmed embolic stroke of undetermined source during their hospitalization. They must have no history of atrial fibrillation and no history of anticoagulant therapy, as well as no contraindications for anticoagulant therapy in the future. Also, the hemodynamically significant valvular heart disease was the exclusion criterion. Moving on to the results, the endpoint was observed in 14 patients. And patients with Katowice score over 2 had higher risk of reaching the endpoint. The same situation was the patient who reached Katowice score over 3, as well as patients with the Katowice score over 4. Moreover, patients with the presence of excessive supraventricular ectopic activity had also a higher risk of reaching the endpoint. And patients with National Institute of Health Stroke Scale over or equal 4 have a higher probability of reaching the endpoint during the follow-up. And just before concluding, I would like to emphasize the following findings. The incidence of confirmed atrial fibrillation experience of recurrent ischemic stroke was more likely in patients with higher CHA2DS2-VASc score, as well as in patients with BMI over or equal to 25, in patients with excessive supraventricular atrial activity, with ectopic atrial tachycardia, or with NIHSS equal or more than 4. And to sum up, our studies suggest that higher risk of atrial fibrillation occurrence or recurrent stroke might be connected with higher CHA2DS2-VASc scores, with the presence of ectopic atrial arrhythmias, as well as extent of stroke damage and body mass index. Thank you for your attention, and now I would like to invite you to the discussion.
Congratulations on your data. Do we have any questions?
How many patients? Because your endpoint was AF.
Yes.
In this 2 years follow-up. And how many patients had AF and how many strokes experienced?
Yes, 6 patients have recurrent stroke, and in 10 patients we observed the atrial fibrillation confirmation, but in 2 patients have both of them. So to sum up, there were 14 endpoints.
Remaining patients, you mean what was the cause of the stroke? Because only 10% of patients had atrial fibrillation, yes, and remaining did not have, yes. So, what was the reason of recurrent stroke?
We don't know, because the criterion of the including was that every patient have the stroke of undetermined source.
And this recurrent stroke was also without any reason, yes?
Yes.
Thank you for answering the question. If we do not have any other questions, I believe we can proceed with the next paper.
Thank you.
Thank you. Congratulations. Thank you. In that case, we can move on to the paper regarding sort of novel idea, machine learning, so a bit of artificial intelligence, and Mr. Krzysztof Irlik with the machine learning-driven heart failure risk assessment in diabetic patients, exploring the influence of MAFLD. The floor is yours.
Okay, so good morning, distinguished jury and fellow students. My name is Krzysztof and I represent the Department of Internal Medicine, Diabetology and Nephrology in Zabrze at Medical University of Silesia. And today I will have pleasure to show you a study that is at the intersection of cardiology, endocrinology, and computational sciences. And so I would like to show you how can we use machine learning to maybe better understand heart failure and better understand how metabolic associated fatty liver disease can predict heart failure. So there is a complex interplay between heart failure and fatty liver disease, and in this and in the population of patients with metabolic associated fatty liver disease, the non-alcoholic fatty liver disease, the prevalence of cardiovascular disease is much higher. This had been showed in the longitudinal data, in this study, after just over a year of observations, the risk of heart failure was almost 20% higher than patients without non-alcoholic fatty liver disease or NAFLD. So yeah, the researchers from Japan wanted to evaluate the prognostic value of non-alcoholic fatty liver disease. And what they did is they incorporated the data about NAFLD, the non-alcoholic fatty liver disease, into the model that was using the Framingham risk score and calcium score. And what they found out is that incorporating the data about NAFLD significantly increased the c-statistic of this model. And it was statistically significant and clinically significant. And as you can see on the left, the patients on the right, the patients with calcium score of over 100 with NAFLD had even 5 times greater cardiovascular disease rate than the patients without NAFLD. So yeah, I was talking about non-alcoholic fatty liver disease. However, this is really a diagnosis of exclusion. So the patient has to have hepatic steatosis, and on top of that, he should not be excessively drinking or have other liver diseases. And this is not really supported by the current knowledge about the fatty liver disease. So in recent years, a new term emerged, metabolic associated fatty liver disease. And the metabolic associated fatty liver disease is defined as hepatic steatosis with some metabolic abnormality, such as diabetes or obesity. And we can see, interestingly, 1 in 10 individuals who fulfill criteria for this new term, MAFLD, metabolic associated fatty liver disease, does not fulfill criteria for the old term NAFLD. However, this group with MAFLD, the new term, have greatly increased cardiovascular risk and compared to general population and comparable to those with NAFLD. So there are a lot of people who have MAFLD but not NAFLD, and we don't consider them in the same subgroup. So in this study, we aim to develop machine learning models that predict heart failure risk in diabetic patients, with the focus on the presence or absence of metabolic associated fatty liver disease. And to do that, we conducted a study. We collected data of over 1,700 patients, consecutive patients from a diabetology ward, and we adopted a cross-sectional design because the event rate in the follow-up was just too low to make a longitudinal study. And eventually, about half of the patients had metabolic associated fatty liver disease, and 20% were diagnosed with heart failure. And we compiled a comprehensive set of parameters such as data on demographic data, laboratory values, data related to diabetes and comorbidities. And what we then did is we wanted to select the most predictive of these parameters to include in the model at the end. And so to do that, we used a machine learning technique. It is called chi-squared feature selection with Monte Carlo approach. So what we really did is we repeatedly sampled from our patient population. We then ran a chi-squared test to compare the groups with and without heart failure. And if a feature was consistently, significantly linked to heart failure, then we included it into the model at the end. So this process of feature selection would highlight the most important parameters for the prediction, and also make the model easier and more understandable and easier to interpret. So here you can see the most discriminative parameters for each group, because we repeated this approach for all patients, and for patients with MAFLD and without MAFLD. And for all patients, the most discriminative predictors were age, type of diabetes, as well as diagnosis of atrial fibrillation, hyperuricemia, and estimated glomerular filtration rate. And for the group with MAFLD, just 3 of these parameters were sufficiently predictive. These were atrial fibrillation, hyperuricemia, and eGFR. And for the group without MAFLD, only age and eGFR were sufficiently predictive. So as an example, let's take atrial fibrillation as one of the predictors. It was significantly linked with heart failure in patients with muffled, but not in muffled. And so here we can see that if a patient had atrial fibrillation and muffled, he was much more likely to have heart failure. Whereas when the patient had muffled, did not have muffled, but had atrial fibrillation, then it was pretty much the same likelihood of having heart failure or not. So here we can see on this predictor that it can be very good in one population, like here in patients with muffled, but not really in patients without muffled. So then we developed models using multiple logistic regression. And we did this for each of the subgroups and for all patients. And the C-statistic of the model for all patients was 71.99. I'm sorry, the C-statistic was 0.83. For the model of patient with including patients with muffled, it was 0.78. And for the model without muffled, it was 0.84. And the number of correctly classified patients was higher in subgroups using the data about muffled. As you can see, 76%, 73, compared to just 72 in the model created for all patients. So based on this, we can conclude that incorporating muffled status into the machine learning models may provide better accuracy for predicting heart failure risk in diabetic patients with less parameters. And this could be potentially used in more individualized management. However, I agree that this certainly needs to be repeated in longitudinal design and externally validated. So thank you for attention, and I would now welcome any questions or comments you may have.
Thank you for this interesting approach. Do we have questions from our jury?
Congratulations for this work, the concept and the way of analysis. You show at the end the ROC curve, and we see that actually the shape and the area under the curve, so 76.3. No, area under the curve is 0.84.
Yeah, for the model without
the
muffled.
model without a muffle. Yeah. So actually, how would you interpret this? Because it means that you don't incorporate the model, you have better diagnostic accuracy, so both specificity and sensitivity.
Yeah, so it's like if we know that a patient do not have muffled, we can like use the model for the patients without muffled, and then we gain better accuracy, both if we look at the correctly classified patients for the optimal cutoff point on the ROC curve, as well as if we look at the area under the curve of this model. Then if we use just the curve for all patients, where we don't know if the patients have muffled or does not have muffled.
Yes, okay, but what is the definition of a muffled clinically? What is exactly? And
yes.
How did you diagnose? What are the criteria for this muffled?
So metabolic associated fatty liver disease is kind of similar to this old term non-alcoholic fatty liver disease. So the patients need to have hepatic steatosis. It can be diagnosed most commonly by ultrasonography, but it can be done by CT or some other modalities. And then the patient have to have some metabolic abnormality. It can be diabetes mellitus.
Okay, but it is very general. But in this group, what was this muffled diagnosis?
So the patient had to have hepatic steatosis on the ultrasonography exam.
Only?
Yeah, because they all had diabetes.
Only ultrasonography and
ultrasonography or CT, but yeah, that's the only criterion.
But what was the function of the liver?
So the function of the liver is kind of irrespective of whether they have fatty liver disease or not. However, we did include some parameters in our model because we have really comprehensive parameters, like 52 parameters in total. And if I remember correctly, we included the parameter, I think, of, I'm sure ENR was there included. So it's like the how the liver functions. And it was not predictive in these models, not significantly predictive.
So it is very general because it is only quantitative parameters that there is only status of the liver, yes?
Yeah, it's qualitative parameter, yeah.
Okay.
So in brief, you're trying to say that in the patient, what's the clinical impact, the practical impact? If the patient has a diabetes and fulfills the very general definition of muffled, this is the greater prediction for heart failure. Do you understand?
Then we can predict more accurately the risk of heart failure and do this by using less parameters, just 3 in our model and not 5.
So 2 short questions. Heart failure, you mean both heart failure with reduced ejection fraction and preserved? Did you discriminate it?
Yeah, so I mean both with preserved and reduced ejection fraction. We did not classify it into one or other category because not all patients had ultrasonography, echocardiography. And I think it's important to note that in this metabolic associated fatty liver disease, on the first slide, I show you that patients have increased risk of heart failure. And this is especially important. I mean, the incidence of heart failure is especially high for heart failure with preserved ejection fraction. I would say this metabolic phenotype of heart failure with preserved ejection fraction.
Okay, because the paper, this concept is very interesting. There are a lot of patients. It is important, in my opinion, to include only rather HFpEF patients because this is associated with diabetes mainly. And a lot of patients in your group might have different types of heart failure, completely not related to diabetes. What was your input, personal input in the work?
Yeah, so I will say that, but also to comment on that, that I agree that this is mainly important in the context of heart failure with preserved ejection fraction. However, as you can see, we wanted to make this model quite simple. So, for example, we did not include the parameters of like NT-proBNP or natriuretic peptides in the model because we just didn't have these parameters. And I think in practice, it usually looks like that we don't have these parameters. And when it comes to our personal input into the study, then the members of the Student Scientific Association collected all of the data of the patients. And we were not directly involved in the design of the study. However, I was directly, I have like a hotline to our data scientist from the Silesian University of Technology, and we jointly interpreted the results.
Congratulations on impressive work. From epidemiological point of view, cross-sectional study design had the lowest power to infer risk and causality. Will you follow up the patients to verify really the outcomes and heart failure development in the future to verify this predictive model?
Yes, so I agree that the cross-sectional design is one of the main caveats of this study. And we are already collecting follow-up of these patients with endpoints such as new onset heart failure or even heart failure hospitalizations for patients who already had heart failure diagnosed.
Thank you.
Maybe last question. You said that the steatosis was recognized based on ultrasonography. Does it mean that ultrasonography was done in all your patients analyzed?
Yeah, I think that's an interesting question because actually the answer is no. not every patient had ultrasonography, because these are like consecutive patients admitted to our ward. So, but I think most patients had the ultrasonography. But for those who did not have, then we were basing our diagnosis on the history, so maybe prior studies, ultrasonography studies, or just assuming that there is no hepatic steratosis.
Okay. So thank you very much for the presentation.
Thank you. Thank you very much.
Okay. Thank you. And now moving on to paper number 11. And Ms. Judyta Znamirowska with the paper regarding echocardiography markers of left ventricle hypertrophy and concentric remodeling, limitations in diagnostics. The floor is yours.
Honorable jury, dear colleagues, my name is Judyta Znamirowska. I have a pleasure to represent the first department of cardiology, and I would like to introduce results of study called Echocardiography Parameters of Left Ventricular Hypertrophy and Concentric Remodeling, Diagnostic in Hypertrophic Cardiomyopathy, Cardiac Amyloidosis, and Fabry disease. Cardiac hypertrophy is an abnormal enlargement of heart which is diagnosed with various examinations. It is connected with increasing risk of sudden cardiac death and caused by many diseases. Myocyte cardiomyopathy, disarray, and myocardial fibrosis constitute the histological features of hypertrophic cardiomyopathy. Cardiac amyloidosis is a progressive infiltrative disease that is caused by deposition of amyloid fibrils. Fabry disease is a multisystemic disorder characterized by accumulation of lysosomal globotriaosylceramide secondary to decreased activity of alpha-galactosidase in cells. The aim of the study was to compare echocardiography parameters of left ventricular remodeling among patients with increased left ventricular wall thickness and the final diagnostic of hypertrophic cardiomyopathy, cardiac amyloidosis, and Fabry disease. Study group consisted of 86 patients. Average age was 55.4 years, and 59.5% patients were males. Thickness of intraventricular septum above 10 millimeters in males and 9 millimeters in females occurred in everyone, and it was an inclusion criterion. In the group, 76.8% patients were finally diagnosed with hypertrophic cardiomyopathy, 15.1% with cardiac amyloidosis, and 8.1% suffered from Fabry disease. The most frequent comorbidities were dyslipidemia, systemic hypertension, and ventricular tachycardia or ventricular fibrillation. Left ventricular mass index, relative wall thickness, intraventricular septum posterior wall thickness ratio, and left atrial area were echocardiography parameters which were evaluated in the research. Relative wall thickness and left ventricular mass index are necessary parameters to determine forms of remodeling. Both parameters above norm are associated with eccentric hypertrophy. Eccentric hypertrophy is defined as left ventricular mass index above norm and normal relative wall thickness. Intraventricular septum posterior wall thickness ratio is a parameter which reveals symmetrical or asymmetrical form of hypertrophy. The value more than 1.3 indicates asymmetrical hypertrophy. The results of the study. Increased left ventricular mass index occurred in the vast majority of patients with hypertrophic cardiomyopathy and cardiac amyloidosis, and in all patients with Fabry disease.
Relative wall thickness above norm was presented among over 90% patients with hypertrophic cardiomyopathy and cardiac amyloidosis, and in 57.1% patients with Fabry disease. Based on analysis of RWT and LVMI, it was possible to reveal that concentric hypertrophy occurs in the was diagnosed with different frequency among patients, but the most often in patients with hypertrophic cardiomyopathy. Results show that eccentric hypertrophy was observed more often in patients with Fabry disease. It was 42.9% patients, and this result was statistically significant. Abnormal intraventricular septum posterior wall thickness ratio was diagnosed more frequently in patients with hypertrophic cardiomyopathy, and it was 79.7% patients, and it was statistically significant. Increased left atrial area appeared in most patients and with various frequency. The results allow to draw conclusions. Although cardiac hypertrophy is a typical sign, it does not occur in all subjects with hypertrophic cardiomyopathy, cardiac amyloidosis, and Fabry disease. More detailed analysis, including the form of hypertrophy, such as concentric, eccentric, symmetrical, or asymmetrical, as well as left atrial remodeling, are more characteristic for the specific diseases as hypertrophic cardiomyopathy, cardiac amyloidosis, and Fabry disease. Thank you for attention.
Thank you. Congratulations. We have
congratulations for the work. 3 well-defined subgroups of patients. My question is related to the amyloidosis group. This was 16 patients with 13 patients, yeah?
Yes,
with amyloidosis. What types of amyloidosis did you include? All these patients, these were AL amyloidosis?
Yes, everyone was AL amyloidosis.
So no transthyretin amyloidosis?
No, because it's a very rare disease, so we haven't got this luck to find this patient.
In our cardiology center, there were patients with TTR, but they had another exclusion criteria, so they aren't in our study.
If you could also comment about the hypertrophic cardiomyopathy group, because the remodeling in hypertrophic cardiomyopathy patients is quite dynamic process. So at which level of the disease did you look at these patients? Because we may have a patient with already dilated left ventricles. Did you look at the time duration or the history of hypertrophic cardiomyopathy?
We tried to include patients in the early etap of their disease, but not all patients had, for example, all require parameters, so we excluded that hospitalization, and we had post hospitalization. So more of them had early etap of their disease.
Okay.
Congratulations on the work, but this is a difficult topic. In the future, you should index the left atrium to about the surface area, because there are very simple comorbidities like obesity that might interfere. One question: your inclusion criteria was interventricular septum above 10 or 9 millimeters, Can you comment on why? And if there's like about 20% of patients with hypertrophic cardiomyopathy, which you showed that they did not have hypertrophy, how did you diagnose it? The cardiomyopathy?
All patients in our study had hypertrophy of left ventricular.
But your inclusion criteria was lower, were too low. You more than 10 millimeter. The criteria is 12 millimeter. So what is the concept for the cardiomyopathy?
Another criterion was 15 millimeters for left ventricular wall thickness. But
did you have the genetic counseling? This is the aim of my question in hypertrophic cardiomyopathy.
Excuse me, can you
did you have the knowledge that the patient without, like for example, with the interventricular septum 11, they have like genetic results for cardiomyopathy or something?
Not all patients had genetics tests for cardiomyopathy.
Because this is for me not clear. Yeah. Or for all three, yes. However, it is very broad inclusion criteria. For example, 11 millimeters, and to diagnose the cardiomyopathy. This is very, in my opinion, broad.
But the guidelines show us that 10 is the cutoff hypertrophy.
Okay. In this, yes, of course, but in this case, half of us have the hypertrophic cardiomyopathy.
10 is the
limit.
Yes.
We had,
however, therefore, there should be the analysis of the comorbidities in this 20%. I mean, I'm still talking about this 20% in the group of HCM without the hypertrophy. But anyway, it's interesting work.
Okay, thank you.
Thank you. After so long and thorough discussion, I believe we can move to another paper of yours, the implementation of use the electrography of left ventricular hypertrophy between hypertrophic. That was comments, right?
Nie trzeba. Honorary committee, dear colleagues.
Try to start here.
Honorary committee, dear colleagues, my name is Mateusz Tomeczek, and I have pleasure to present you the results of our study, limitations of the electrocardiographic criteria of left ventricular hypertrophy in differentiation between hypertrophic cardiomyopathy, cardiac amyloidosis, and fibrous disease. Left ventricular hypertrophy is a condition of the heart when thickness of the left chamber's muscle is over the norm. It can be caused by many genetic disorders or acquired pathologies, and changes in myocardium morphology can lead to abnormalities in ECG record. HCM consists on hypertrophy of cardiomyocytes, which leads to overgrowth of the heart, not but overstrain. Cardiac amyloidosis is a disease where these five proteins are deposited in extracellular matrix. And fibrous disease is a condition where deficiency of alpha-galactosidase A activity leads to accumulate the globotriacyl ceramide in site-affected cells. In diagnostic, we can use echocardiography or cardiac resonance to define the thickness of left chamber's muscle, or we can use enzymatic test and myocardial biopsy to confirm the reason. But the lowest cost non-invasive and easily reproducible tool is ECG examination. The aim of our study was to compare LVH ECG criteria among patients with echocardiography features of cardiac hypertrophy in regards to the final differential diagnostic, including HCM, cardiac amyloidosis, or Fabry's disease. In our study, we include 91 patients, in average age 55.7, hospitalized between 2010 to 2022. Males make up 58.4% of patients, and the main inclusion criteria was confirmed LVH in DTE. 78% of patients had HCM, 14.2 had amyloidosis, and 7.7% of patients suffered from Fabry's disease. We manually analyzed 20 leads 30-second ECG records. 8 LVH criteria were assessed. We created some groups according to those criteria. Patients that fulfilled any criterion or fulfilled one and more criteria. Group with one criterion. Group that fulfilled 2 to 4 criteria. Group that fulfilled between 5 to 7 criteria. And patients that fulfilled all 8 criteria. We also wanted to find out the most common criterion in all groups. This is exemplary ECG record of our study. This patient suffered from amyloidosis, and he fulfilled 3 ECG LVH criteria: Sokolov-Lyon index, Cornell index, and maximum R plus maximum S in precardial leads. Results of our study. Any criterion was fulfilled by 42.4% of patients with HCM, 46.2% of patients with cardiac amyloidosis, and 42.9% of patients with Fabry's disease. One criterion fulfilled, the most frequently in cardiac amyloidosis. In HCM, it was 21.1% of patients, and in Fabry's disease, it was 14.3% of patients, and it is at the limit of statistical significance. Between 2 and 4 criteria was fulfilled by only 7.7% of patients with amyloidosis, 33.8% of patients with HCM, and 42.9% of patients with Fabry's disease, and it also was at the limit of statistical significance. Between 5 and 7 criteria was fulfilled only by HCM. The most common criterion in the whole population was V6 greater than V5. In HCM, it was Cornell index. In cardiac amyloidosis, it was V6 greater than V5. And in Fabry's disease, it was equal Sokolov-Lyon, Cornell index, and maximum R plus maximum S in precardiac leads. Gabner index and R in AVL criterion was observed only in patients with HCM, and it was statistically significant. To sum up, not all patients with LVH in TTE had LVH criteria in ECG. This mismatch was most frequently observed in patients with cardiac amyloidosis or Fabry's disease, and the knowledge of all 8 ECG LVH criteria are helpful for making the diagnosis. Thank you for your attention, and I want to invite you for discussion.
Thank you. Congratulations. I would like to ask you a question because you showed that there is a discrepancy between the level of echocardiographic parameters of hypertrophy and the electrocardiographic signs you analyzed, and it's a common finding. So how would you define the role of electrocardiographic signs of hypertrophy, because we have a lot of doubts about their usefulness, but can you distinguish how useful they are in our daily clinical practice? How can we use them?
I think because we all know that that is morphology change in hypertrophy and in Fabry's disease and cardiac amyloidosis. So we mismatch is accurate, but we think that analysis of ECG criteria, all of them, can help us to find out this rare disease as a Fabry disease. For example, this Gabner-Ungerleider index and REAVL, which is observed only in patients with HCM, but we want to check the greater database for this.
Okay, thank you, because you answered my question in relation to the study, which is of course good. I just wanted to say that, because I think the general picture is important. Hypertrophic criteria are important in patients like we see in daily practice with hypertension, in whom we need to perform echo. But that's what the guidelines say, that we need to distinguish those patients and refer them for transthoracic echocardiography. And the second fact is that if we have this hypertrophic signs, we need to interpret the STT abnormalities in a different way, because they might be a sign of overload, not ischemia. And in your study, the group with cardiac amyloidosis, per se, is a group in which we do not have a great extent of. Actually, we have the opposite. We have low voltage in these patients, and yes, this is what you pointed out. The discrepancy is important. Very good. Thank you.
Yes, I have one comment and one question, because we know that that we have many criteria of left ventricular hypertrophy in electrocardiograms. We have criteria for limb leads, and we have a criteria for precordial leads. They're quite different, and sensitivity of these criteria are not very good. And specificity is better, but also not very high. And the problem is that if you find only one of these criteria, we can say, yes, this patient maybe have hypertrophy of left ventricle. The number of this criteria is related to the different location of the heart in the chest. It can the heart can be right or left-sided, and so on and so on. And I think that is very difficult to say that one of these criteria is more common in this disease, and this other criterion is more characteristic for other disease, because it depends on the patient, and you should have much more patience to say exactly that, for instance, our amplitude in V6 more than V5 is more frequent in, for instance, Fabry disease. Now I think that you can't say it.
To be sure, this one is better than the previous one. I mean, the work, the concept, and it's more logical, in my opinion, the way of presentation of our results. One question: what was your input? I understand that you yourself manually assessed all the ECGs.
Yes, we manually assessed all ECGs from archivum of our hospital. We make all the database, and we count the statistica in Q-square in Fisher modification.
Okay, thank you.
Thank you so much. I believe the discussion is over, and we still need to proceed. Okay, congratulations. We still need to proceed with the two last papers. And now, Alexander Urbaś and fascicular arrhythmia, clinical pathological characteristics. Somebody need to introduce themselves?
Good morning, ladies and gentlemen. My name is Alexander Urbaś. I represent the student club of the first department of cardiology in Katowice, and I want to present you today the study with the theme of clinical pathological characteristics of fascicular arrhythmia. Fascicular arrhythmia is a wide group of ventricular heart rhythm disturbances, consisting mostly of PFC, premature fascicular contractions, and tachycardia. They all depend on highly specialized conducting system, ventricular part of this system, as the place of origin of this arrhythmia. Our study is focused on premature fascicular contractions, and as you can see, this kind of contraction is relatively narrow. This one here is about 105 milliseconds, and that's its main similarity to premature supraventricular contraction, PSVC. However, PFC is in most cases not preceded by P wave, and it's characterized with compensatory pause. So a classic premature ventricular contraction is. In the case of premature supraventricular contraction, we will see non-compensatory pause. Nevertheless, PFC morphology can cause misinterpretation. So the PVC can be misinterpreted as PSVC, especially in Holter records. And at the same time, this topic is relatively niche, and that leads us to the aim of our study, which is to present and analyze clinical pathological characteristics of such arrhythmia. Our study is based on retrospective analysis of EKG Holter records in search for fascicular arrhythmia. Our inclusion criteria was at least 5 PFC per day, and we consider ventricular contraction as fascicular if a premature complex of such contraction was under 120 milliseconds. If the native QRS was under 100 milliseconds. If this native QRS was lasted longer than 100 milliseconds, then criteria was widening of premature complex less than 15%. Finally, 51 patients were included to our study. 51% of them were male, and the average age was about 60 years old. Mean ejection fraction of left ventricle was about 49%. Moving on to the results, first of all, we can say how frequent were PFC, and the median is 1,383 per day. However, in 55% of patients, this number was higher than 1,000 per day, and in 27% of patients, this number was higher than 10,000 per day, which can be considered as relatively high in comparison, for example, to classic PVC. As I said before, the QRS of PFC is rather narrow. Our data match this information, of course. This mean QRS of PFC was about 120 milliseconds, as the sinus QRS was about mean QRS width of sinus QRS was 106 milliseconds. Mean coupling interval of PFC was about 566 milliseconds, and we can see that the group of males and females were differentiated in terms of, for example, ejection of fraction of left ventricle, which was slightly higher in female. However, we can also see that in group of male, the PFC frequency was significantly higher, as the mean frequency in men was 9.5 thousand per day, and in female only 3.5 thousand per day. PFC were in most cases multiplicated. In 53% of subjects, it took form of the pulse, and 47 patients presented NSVT. At last, we can compare the group of patients with frequent PFC and non-frequent PFC. And in that context, when I say frequent, I mean that this number of PFC per day is higher than 10,000. First thing we can see already is that such situation was much more common in men, as the 40% of male presented frequent PFC and only 15% of female. The second thing we can mention is that these patients with frequent PFC had wider QRS complexes. And I mean both ectopic and native QRS. In terms of clinical characteristics, no significant differences between these two groups were observed. And, well, I'm sorry. And to sum this all up, we didn't see any significant correlation between number of PFC and any clinical pathology. However, the study group of 51 patients isn't reliable enough to consider this conclusion as final, and it only indicates the need for further analysis with wider group, which already is in our plans, actually. Now I would like to invite my dear colleagues up here, and thank you for your attention.
Thank you. Do we have any questions on the paper?
Thank you very much for your nice presentation. It was like 6,000 of Holter recordings, yes? So they are 3 lead recordings, yes? Or there are some 12 lead recordings included also?
Thank you for the question. So there were some 12 derivation ECG Holters, but we focused on the 3 derivations because most of the patients had that kind of results.
Okay. Second comment is based on that you stated that you didn't found any clinical correlations, but I just looked at your slides, not analyzing your data. So there is a male sex and low ejection fraction probably are correlated because there are quite a difference in the ejection fraction between the male and female. So roughly we can interpret it that way, that the male were more had lower ejection fraction than their illness, which is as the presentation with extrasystole of fascicular origin more pronounced. Thank you.
Maybe say a few words. Very fine paper, and I think according to the comments of Dr. Filipecki, that I think that there's no difference if you analyzed this QRS complexes from 2 lead or 12 leads Holter recordings, because the time of this QRS is the same. But my question is, how often, or maybe always, you saw retrograde P wave? So QRS, and after that retrograde P wave, negative in 2, 3, and AVF lead. Do you remember? How often have you seen retrograde P wave after this PVC? Because it's very, very typical for this type of arrhythmia, and very often very typical to ventricular premature ventricle arrhythmia or contractions, that we can see in almost 40 or 50% of cases retrograde P wave. So we have ventricular contraction, and next retrograde conduction to the to the atria and P wave.
Thank you for the question. So we didn't measure the percentage of retrograde P wave, but we saw some cases, some patients with this wave, but we didn't focus on it in this study.
Okay, so I suggest to do it in the future because it can be very interesting, and you can measure a time RP because this time is very important in differentiation of supraventricular arrhythmias, re-entry arrhythmias, and it's very important to in differentiation of arrhythmia from atrioventricular node and from his bundle and from the muscle of ventricle, left or right ventricle, and it can be very interesting.
My question is about this group in whom was more than 10,000 premature ventricular contraction. So it is well known that what is very frequent arrhythmia, it can cause tachyarrhythmic cardiomyopathy. And you show that there is no differences in clinical manifestation of this between these patients. So I am afraid that it is very, it is maybe too early to draw such conclusions, because you need to have more follow-up, especially in these patients with very frequent arrhythmia. So my question is, how long, what is your follow-up in this group?
So when we investigated the Holter ECG results, we also checked the follow-up. So the next Holters of these patients, and after the ablation treatment, for example, but we didn't use this data yet, and there was a significant rate of cure of this disease.
Okay, you said ablation, so you made interventions, so it is not benign arrhythmia, but the conclusion is that there is no differences between manifestation, clinical manifestation in these patients. So how many patients experience ablation?
Exactly, we didn't do a follow-up yet, and we are collecting the data about the ablation.
Okay.
Thank you. Thank you for the discussion. I believe we're free to go. So now the last paper, Agnieszka Adamiec and hypertrophic cardiomyopathy, so preclinical history of patients with HCM reflecting the course of the diagnostic process. The floor is yours. Pani sam przeczytać slide.
Good morning, ladies and gentlemen. My name is Agnieszka Adamiec. I'm representing the first department of the cardiology in Katowice, and today I would like to present you the study titled Preclinical History of the Patients with Hypertrophic Cardiomyopathy, Reflecting the Course of the Diagnosis Process. Hypertrophic cardiomyopathy is a relatively common genetic heart disease, which is associated with a high risk of sudden cardiac death. The 5-year survival rate among the hypertrophic cardiomyopathy population is lower than among the population matched to the age and sex. Hypertrophic cardiomyopathy lower the survival and also increase the risk of sudden cardiac death. So if it's detected earlier, we can prevent of the early sudden cardiac death. So here is an example of echocardiography of a patient with hypertrophic myocardiography. We can see on this echocardiography that the left ventricular is hypertrophic, and also there is a ST segment elevation, which can indicate for an ischemia. Here is an example of echocardiography of the patient with hypertrophic cardiomyopathy. among the register of cardiomyopathies from European Society of Cardiology, we can see that the mean age of the diagnosis of the cardiomyopathy in Europe is around 47 years. 56% of the patients have the symptoms which were the reason for diagnosis. So we can assume that also not only in the European population but also in Poland, the symptoms are the main reason for the diagnosis. So we aimed our study to analyze the preclinical history of the hypertrophic cardiomyopathy patients and the course of the diagnostic prior to the HCM diagnosis. So the study was a single center retrospective cohort analysis of 85 patients who were hospitalized in the first department of cardiology in Katowice in time between 2014 to 2022. In our study, the patients were included with the diagnosis of the hypertrophic cardiomyopathy between time 2014 to 2022 in the first department of cardiology, and the patients with the diagnosis in other period of time or with the diagnosis outside the department or with the cardiomyopathy diagnosis other than hypertrophic cardiomyopathy were excluded from our study. The parameters which were analyzed are following: the types of referrals to the hospital, divided to planned and urgent, occurring symptoms, comorbidities, and the family history. So we have analyzed 85 patients. They were 43 males and 42 females. The mean age of the analyzed group was 64 years, and the mean age at the time of hypertrophic cardiomyopathy diagnosis was 51 years. Now let's move to the results. The referrals to the hospital were divided into planned and urgent hospitalization. Planned hospitalization accounted for more than 80% of all types of the hospitalization. Among the planned hospitalization, almost 80% were the referral from the specialist clinic, and among the urgent hospitalization, transfer from other hospital were the most common. On this chart, we have all types of admission to the hospital, and we can see that as many as 2/3 of all admissions were due to referral from a specialist clinic. Dyspnea and exertion were the most common symptom. The other symptoms which our study patients experience are angina pain, heart palpitation, systolic murmur, syncope, vertigo, and dyspnea at rest. 13 patients were completely asymptomatic. The BMI analysis shows that almost half of the study population is overweight, and also almost 1/4 has an obesity class 1. The most common comorbidity was hypertension, and the other comorbidities present in the study group were heart failure, ventricular arrhythmia, atrial fibrillation, and supraventricular arrhythmia. The analysis of the family history showed that at almost 20% of cases, there were a sudden cardiac death in young age in the family history. 14% of the study group has a family history of cardiomyopathy, and 13% of patients has a hypertrophic cardiomyopathy in the family history. We found a positive correlation in a chi-squared test between the occurrence of cardiomyopathy in the family and the lower age of hypertrophic cardiomyopathy diagnosis. To conclude, the diagnosis of hypertrophic cardiomyopathy is often made at an advanced age, mainly due to overt clinic presentation, comorbidities, and exacerbation of HCM. People who are aware of the presence of cardiomyopathy in family history are more likely to get the diagnosis at an early age, and efficient screening is a main goal for an early diagnosis. Thank you so much for your attention, and now I'm inviting you to the discussion.
Thank you for presentation. Do we have any questions?
Congratulations for the presentation. This is again important clinical topic. Actually, you confirmed the recommendation that we should look at those group of patients much earlier, and specifically to perform at least echo study in family members. But in practice, we know that it's not always work as we wished. Do you think at which other parameters could we look when performing the echocardiography, because we also know that it's not always the best method to recognize the hypertrophic cardiomyopathy. Performing the genetic study, of course, this is crucial, but we still know that access to genetic studies is limited. So actually, in practice, the imaging methods are the first line methods. What would you suggest? Do we have any preclinical parameter that could show us the risk of familiar hypertrophic cardiomyopathy?
Okay, so thank you for the question. I don't know if I understood right, but maybe we can use also the magnetic resonance, cardiac magnetic resonance. But when it comes to preclinical history of patient, when they come to the diagnosis, maybe on the first place in ECG and also echo, not the magnetic resonance on the first place.
You showed actually the patients were referred to the hospital due to the symptoms, and this was the major reason
yes,
that patients
that
were referred to the cardiologist. So my question is, should we look at the other imaging parameters? You pointed out CMR. Do we have any data on other imaging parameters that we can use in non-asymptomatic patients? Yeah.
So basically in our study, we didn't analyze these parameters, but I think when we have asymptomatic patients, we should consider their family history, and when it's positive, we should also consider their genetic tests, but they are not so commonly available.
So you didn't actually look at, for example, deformation parameters like strain measured by echo?
No. We only analyzed the symptoms, occurring symptoms, comorbidities, and the family history. We didn't analyze any imaging pictures.
Okay, thank you. Any other questions?
Interesting work. One question: to put your results in clinical practice, you said that the mean age of the diagnosis was 50 years old. Did I notice right?
51.
So the problem is that the patients, they do not come to doctors at all, or they are not referred to cardiologists. Where's the problem? Based on your results or opinion?
So we think that the problem may be that people don't go to the doctor, the cardiologist. They come to the doctor when they have symptoms, and they usually may have symptoms at an advanced age, like 51 years old. And as we found the correlation that when the people are aware of the hypercardiomyopathy or cardiomyopathy in the family, they are doing the screening before they have the symptoms.
Okay, so the reason is both on the patients and doctors.
Yes.
Thank you.
Thank you.
I would like to congratulate the aspect of preclinical history, not only echocardiography, but your point of view. It's for me very important.
Okay, thank you.
For clinical practice. Thank you.
Thank you.
Congratulations. So all of the submitted papers have been presented, and we congratulate you all of the authors and participants of our session. Now is the time I would like to cordially invite the head of the jury to give us a speech or have some words to our authors to close the session today.
Okay, so if I may summarize on behalf of the jury, we already made our notes according to all this presentation, so you will receive all these notes. But let me share some thoughts about this session. First of all, I would like to stand up. Congratulate to all of you for the presentation, and specifically to the tutors of your work, because the quality of the, let's say, work is also related to the tutor work. The concept of the study is usually the concept that is proposed by the tutor, and we can easily see looking at your results and your way of presentations. So once again, congratulations for your work and involvement. My other observation is that I must say this is a session which is actually related to one center. When we look, 10 of 14 papers are coming from the one center and from the one tutor. So it's a good news and the bad news. The bad is that the activity of the other centers is rather low. So congratulations for the first department of the cardiology here in Katowice. My next observation is actually the dominant pathology that has been elaborated during this session is the hypertrophic cardiomyopathy or hypertrophy in general. So it also reflects the interest of groups that are doing the research. The good thing is that actually majority of this presentation, these were clinical work, but of course experimental work is also very welcome and has also very known input to the science at all. And the last thing, I think that we will continue presenting your results in English, and we will continue the discussion in English, because I think this is also the good opportunity for you to be more familiar with the language and also to be active in the discussion. So these sessions actually are some kind of practice for you. We had a discussion before with the jury whether we should switch to Polish, but as you noticed, automatically we're continuing the discussion in English, and let's keep to this, I think, good practice. So thank you for your presence and for your results, and we will deliver our notes and opinion to the organizers, and we will receive the results of your presentation very soon. Thank you.
Thank you so much, Professor Kukulski, for these words. Now let me express the words of thank you for all of the members of our scientific jury. It is utmost pleasure for me to host you here today, and most definitely for our students to listen to all of your discussions and highlights which you talk about after the presentations. Thank you all for attending the session. Now I believe the session of non-invasive cardiology of the SIMC 2023 is officially closed. Thank you so much for the participation, and I shall see all of you as the participants at the closing ceremony today, 4:15, where you will have a chance to listen to the lectures and to get the information about the results. Thank you so much.